So this is a presentation done for the surgical technologist and those wanting to learn ophthalmic cases. And this was produced by Rafael Mendez, CST, on request by Karen Wright at Orchard Ophthalmology. This is not a formal agreement between the CSTs, the union, or the employer. I did not involve any of them. This is a tool only, again, only to help those that want to know the flow of the ophthalmic surgeries from the CST trainer to the trainee as requested. There is an assumption made that the CST or whomever is trying to learn here that they have prior training in the normal flow of operating room cases. So I will not touch into details, but a very basic flow. The statutes of limitation pertaining to surgical technologies, there's a hierarchy. The highest most is the federal laws and regulations. Next one down goes down to the state and county laws and regulations, and under that you have the Association for Operating Room Nurses and Association for Surgical Technologists, and from those you have recommendations of which policies and procedures are born to the organization. And one example of a organization would be like the one I am in here, which is Kaiser Permanente. And then under that you have the individual hospital policy and procedures, which would be the operating room within Kaiser. So you can have two separate operating rooms and they have very similar policies and procedures, but they may have slight variance in certain ways in which they do things, and that's how you're supposed to follow things. Pre-op, from the CST point of view. Preoperative, which is the preparation from the CST point of view. I'm not talking about pre-op as in the day before surgery, that department before they come in. That's why I put preparation in parentheses there. What it is, it's the preparation before the patient goes to the operating room. Before that even happens, you are supposed to have looked into Health Connect or at a glance periodically just to see if there's anything going on. Is there anything that's going to be coming up, following the week before? You want to look a month before, and just to see and have an idea of the type of surgeries you're going to be doing, who's going to be doing the surgery, whether it's going to be a resident or do we need an assistant for a particular case. Any combination of surgeries on the same patient is what you want to look for, because sometimes it may be that you may have a case that says vitrectomy, but you're not sure or you didn't catch that there's also a cataract involved, and that means that it's two separate procedures on the same patient in the same case. Preoperative preparation from the CST point of view. Again, this is not directly from the day of surgery, but this is still kind of sort of a preparation, and this gives you an idea of the type of surgery you're going to be doing the day before, the lineup, who's doing it, that type of thing, just to kind of double check to see if you need anything special. Here I put down that you can double check that Health Connect or at a glance the day before surgery, and some of the things that you would want to look for are changes in the schedule. For example, you might have seen 2 weeks before that there was a cataract, and then there was a vitrectomy, and then there was a cataract, and now they shuffle things around to accommodate the patient, and so then they end up doing the cataract first, and then they did the two vitrectomies to follow after that. You also want to see if there's any cancellations. Potentially it may be a short day. For example, they might just be one case, and you might just have to let somebody know that it's going to be a very short day. There might be some special equipment needed. That's why you might want to take a look. And sometimes some of the medications might have a very short expiration date, and or you may have some medications that might be recalled, or they might be pulled off the shelves, or we may be on back order, and just to make sure that we may have something. And I'll give you a perfect example. Sometimes we may need something called the brilliant blue, which stains the retina part of the eye. That has a very a short expiration date, and so what you would want to do is make sure that the expiration dates on those things are good before you go to the next day, because the last thing you want is to have a patient in the room, you're good to go, and then you find out that the medication is actually expired. If the medication is expired, then obviously you can't use it. You're gonna have some very upset people, because now they're scrambling around looking for the medication that you're gonna need. They're gonna have to call a pharmacy. There's always the what ifs. Like, for example, what if there's no brilliant blue down there in the pharmacy and the doctor actually needs it? And so, just to avoid this headache, you want to just kind of double check, make sure that the day before that you have that type of thing going on. It's not the duty of one individual, it's the duty of all individuals to just double make sure that we have. In collaboration with the OR staff, on the day of the surgery. Now we're moving on to pre-op. While the patient's actually in pre-op, before you even move on to the patient coming to you itself, what you want to do, you want to make sure that you have the appropriate machines, the appropriate microscopes, the laser machines, and any special requests that the doctor might have asked for. So again, the day of surgery, that's what you want to do. You want to help out and bring some of that stuff into the room. More often than not, some of that stuff is brought into the room, or it might be already in the room, but you want to scramble and get some of that stuff if you have a little bit of time. Again, it's no particular person's job. It's a collaboration of the operating room staff. It could be the nurse, it could be meaning the RN, it could be the transport orderlies, or it could be you, or anybody else that can lend a hand. But it's nobody's actual job, but it helps if you can get that in there. The day of surgery, you can bring the machines into the room. Once you place them into the room location, you connect them. You turn on the machines into the on position. Look for any signs of hardware or software warning or probable obstacles that may interfere with the case or cases of the day. If such presents, refer to the staff in the room involved, then the charge nurse. And while those are involved are notified, try and see if you can troubleshoot and fix the problem. And if the problem is fixed, then obviously tell the staff, and so that they can proceed, and we can move on to the next step. If the problem persists and the staff cannot fix the issue, or you can't fix the issue, refer to the charge nurse so that the appropriate contact can be made, like biomed engineering, and so that would be the flow of things. There's a very important point here. Please refer to the process in place. Alert any concerns by calling out a safety check. Once we are ready for the intraoperative process, and you see something kind of out of the ordinary that you think you can question, just call it a safety check. Nobody's going to penalize you for any of that. Nobody's going to look at you funny. Nobody is supposed to do any of that stuff. It's not supposed to be retaliatory of any kind. All it is your concern for the patient's safety, and you're concerned for anything that can potentially cause any harm to the patient or the staff. The intraoperative process is made up of quite a few points here, and I will go into a little bit more detail in a little bit, but it is made up of the patient identifiers, and make sure that you're getting the right patient, right procedure, right side, and right implant if need be. Transportation for the patient to and from the OR bed, thermoregulation, which is the warming body temperature, or in some cases even making patient cold. Also preparation, making sure that it's free of any kind of a pathogen, and pharmacologic, which is medications, that type of thing, and the appropriate instrumentation for the case itself. The intraoperative process, the transportation of the patient to the OR room, the transportation is basically multiple things. It could be the transportation of the patient from the preoperative area to the operating room area, and from the operating room back over to the postoperative area. Also, it could also mean that you're transporting the patient from the bed to the that they came in on to the table, and then or from the table back over to the bed. So you want to ensure that there's proper positioning. You want to make sure that your everything, the way you handle the patient's safety is done appropriately, because the last thing you want is for the gurney that the patient came in on not to be locked, or the wheels not to be locked, and then they start moving over from one place to another, and the bed moves, and the patient ends up getting hurt, falling on the floor, injuring themselves, and that's what you definitely don't want. Again, thermal regulation. Most patients come in with a thing called a bear hugger, and the bear hugger itself is a warming device that blows nice warm air, and usually the patient's in pre-op waiting for the operation to happen for them, and so while they're waiting, they're connected and they're warm, and then but that bear hugger does not follow them. They end up getting disconnected from it. So from the time that they leave the operative area to go to the operating room, they may get cold. The operating room itself is cold. It's usually kept at around 68 degrees, and so they don't have much on anyway, and so when they get there, usually the nurse will hook them up to the bear hugger, the warming device, or the anesthesia provider will do the same, and on our end we will be the ones that are actually already scrubbed in, so we can't really touch that because we're considered sterile ourselves. So but that's one important portion of the thermal regulation. The preparation is usually done by the RN circulator. What I like to do is just once in a while she's doing that, is just to kind of sort of glance over, make sure she's actually preparing the right eye, she's preparing it appropriately, just to kind of sort of do kind of like a little safety check type situation. But that's it doesn't have to get done. I just do it for safety reasons. The intraoperative process continues here, and it's with the pharmacology. Within the pharmacology, you want to abide by all medication policies to ensure safety. You want to make sure that there's a doctor's orders, there's expiration, concentration. You want to make sure that there's some compounding, the mode of administration, and then you also want to ensure that the sterility is maintained. Always wipe with the alcohol wipe, especially on a puncture cap before you withdraw. Over to the left here, you have the 6 rights, and it's a given. It needs to always be observed, and obviously it's the right medication, right patient, right dosage, the right route, which is oral, IV, or intramuscular, and then it says at the right time, and you're supposed to have the right documentation. For the intraoperative process, CST portion of it, you have instrumentation. You have the sterile items that are to be opened in accordance to surgical technology training and instrument. Make sure that when you open these things, obviously you're observing the way that you were trained, and it is done, and it's done within the policy. And obviously each surgical technologist was taught the same way. There's no two ways of opening things. It's always done in it was done in training by when you were in surgical technology school. Always check for the expiration date. Make sure there's no expiration date on the things that you're opening. Check for the integrity of the package. For example, there's no tears. There's no some dried fluid that was there that could have been wet before, and then it dried out, but there's a stain, so it looks like it could be contaminated. There's also obviously sterility indicators inside the trays, and so you want to make sure that these indicators indicate that the tray is actually sterile. Make sure that the instruments are working well and are functioning for its purpose. Sometimes you may look at, I'll give you a perfect example. Sinskis are notorious for being bent. Sinski is a tool. It looks like a little pick with a right angle at the tip. They can get caught in between the tray itself when it gets closed, and so it gets bent. So sometimes when you're opening up that stuff, and you're pulling and you're putting it on your mail stand or your back table or whatever, and you take a look and you see that it's bent, obviously it can be used during the case, so don't wait until it's actually necessary for you to ask for a new one, or a one that is not damaged. So just that's the time that you want to ask for another tray, or maybe one that that comes in a sterile package, individual. And if you need to send your instrumentation to the appropriate location as directed by the policies, when you're all done. And all eye instruments usually go to the decontamination room. And the reason why they all go to the decontamination room is because they're so fine. They're so small. They can get damaged so easily. If you could put them in the pressure washers that they normally put them in these big machines they're like these big ginormous dishwashers, they can get dislodged out of the tray, and they're just kind of jumping around, jumping around, getting damaged inside these machines. So in order to avoid that, we keep them in the trays, we send them to decontam, and they put them in a smaller like dishwasher type thing where they won't get damaged. And if you're going to leave them on the rack, sometimes you're done with your cases, you're not the decontamination guy, you're actually the guy that just brings them over to decontam, so you put them in the room. But if you're going to leave them there overnight, where they're going to be taken care of, just spray that disinfectant on it, so that they're not, they don't have that dry blood until the next following day. You want to take care of it, make sure that it's nice and disinfect it from the night before. That way when the first thing in the morning comes to get the instruments to reprocess these things, it's not all gunky dry, like I was saying. There is a surgical pause, and it says, I wrote on here, it says, once the preoperative process is in place and everything seems to be in place, the surgeon will be paged or called into the room to confirm to do a surgical pause or a briefing. The surgical pause is the time when we all agree and communicate all that is relevant to the patient, and each will get to bring up any questions, concerns, or comments. This is the time where we exchange information that is pertaining to the patient. Some of the examples that can be used to cover the surgical pause is make sure that you cover the right patient, the right procedure, and also the right side, as well as the right size of the implant that's going to go into the patient. And any questions that you may have, this is the time to ask, as you want to make sure that everything goes pretty smooth, and you're ensuring the most important part, which is the safety portion of it. Make sure you don't skip any steps. Continuing with the surgical pause, everyone assigned to the patient must be in the room for the surgical pause. The RN circulator, the anesthesia provider, the surgeon, surgical technologist, and they all will refer to the room board for the briefing checklist. And there is a checklist, and some of the items, for example, the patient name, like I mentioned before, the medical record, the surgical site, the type of implants, like I said, the procedure, and anything that's important to the patient itself. After pause, once we are all in agreement, the next step is preparation by the circulator. As the surgical technologist continues to set up, please glance over to the RN circulator preparation to make sure the correct site or surgical site is being done. Again, this is optional. You don't have to do it. I just do it just to ensure safety, making sure that they're just actually preparing the correct site. And then once the site is prepared, wait for the correct amount of time. Again, refer to the policy. So there has to be some time, let for the site to be actually dry before you can do it because of safetyness. Just to make sure that there's dryness. Then you do proceed to drape with the surgeon, and after the surgeon is gowned and gloved, make sure you are not breaking any of the sterile techniques that whether you are doing it or the doctor doing it or any of the other members that are sterile. And then once you are draped, positioned, and with the agreement of all members of the room, we actually proceed. Make sure that the pre-incision pause is done before you hand anything to the surgeon. It's really important because that's part of our policies and procedures as surgical technologists, nurses, and doctors. The next portion of it, as a surgical technologist and or nurse, whoever scrubbed in, make sure that the needed items that you're going to be done for the procedure are on the Mayo stand, the ones that are going to be needed more often than not. And then there's some items that may be needed. Those can be on your back table, of course, and you know that, and that all depends on each individual tech, how they work, but this is how I like to work myself. And all other questionable items pertaining to the procedure must be in the room. So again, when you were not sure to open something and you ask and say, you know what, just have it in the room just in case, that's what is meant by just have it in the room ready to go just in case we do need it. That way the nurse is not running around like crazy looking for it, okay? And obviously it is part of the job, but I just wanted to address it. During the intraoperative process, obviously if a surgical technologist is to be relieved, always abide by the OR policy. It is very important. It is always appropriate to mention, if it is possible during the briefing, that you may be relieved, for example, to go to lunch. If they're going to come in and relieve you for lunch, you may want to mention it to the doc, hey, is this going to be a good case for me to be able to go on? Do you expect anything, not to go so smoothly, so that maybe, do you want me to stay? Do you want me to go? What do you want me to do? So the surgeon would be the perfect person to ask if this is a good time. And most often than not, they'll say, yeah, that's fine, go ahead, go to lunch whenever they come in, just so that there's no surprises. And it is definitely a must that in between surgical technologist to surgical technologist or surgical to RN or RN to surgical tech, that there's a warm handoff. And this warm handoff is basically a report of what you have on the Mayo stand, what it is that you're doing, what type of medications you have, or what you potentially can use or need, or you may need for the next case if it's finishing, any important information that needs to be covered between one individual to another individual. We have arrived at the post-operative portion of this slide, and the usual steps are usually at the end of the case. You want to get a damp 4x4 to wash off some of that betadine. If you don't do that, some of the patients have complained that there's been some itchiness. It can run into the eye and it can irritate the eye itself. You may want to dry with the 4x4, to make sure that it's all nice and dry. The doc will put medications in, for example, some ointments or drops, that type of thing. Then there's usually no shield needed for some of the peds cases. There may be sometimes where there may be some dressing of some sort, but for the most part, you don't want to do a shield because they reach up and try to pull it off. So it's tough for them. And then there's a clear shield for most, but not all cataract cases, and in some cases patch and the non-clear shield in all other cases. Like vitrectomies, that type of thing, they usually do that, or glaucoma, they'll do a patch and a non-clear shield. So they have the two different types. Arriving at the post-operatively portion of this presentation, after the dressing is on, you want to tear down the drapes safely and gently. I say that because you want to make sure that some of the adhesive portion of the drape itself, in some cases, may be attached still to the ET tube or the endotracheal tube. And when you do it roughly, you may extubate the patient, and they could put the patient in danger. And you definitely don't want to do that. It's not a good thing. Again, eliminate all the sharps in the sharps container and do it in the appropriate bins, and make sure you dispose of chemotherapeutic in the appropriate chemotherapeutic bins, and just abide by all policies. Post-operative patient transfers. If the patient cannot move from the bed to the gurney, it is necessary to call for help if one needs it to safely transport the patient over to the other gurney or bed. It is important to understand that the anesthesia provider will be the director of the patient when it comes to moving the patient over to the bed or gurney. So anything that needs to be done to the patient needs to go through the anesthesia first to ensure airway safety. When you move the patient over to the room, usually it's a bunch of people, there's a lot of talking going on, everybody's trying to figure out how it is that they're going to get the patient to move over from one place to another. And in some cases, these rooms can echo, and so we all want to observe the fact that the person that is most important at that point, obviously besides the patient, is the anesthesia provider. Anesthesia provider may still have the endotracheal tube placed inside, and so you don't want to move the patient over or do any kind of abrupt movement of any type or anything like that, because you can always pull out that tube, and you don't want to do that. Again, you put yourself in a bad situation as far as that goes. So the anesthesia provider would be the one to ask if and when we need to move the patient over or reposition or add anything onto the patient. So just ask. At the end of the case, and the patient has already left the room, you want to take the dirty instruments to the decontam room. You want to call the environmental services to clean the room. And so again, you take the instruments, particularly the eye cases, the eye instrumentations, over to the decontam room, and spray them if it's your last case of the day and there's nobody around. If there's somebody there, obviously you don't have to spray them. Make sure you call EVS, which is a crew that comes in and takes care of all the cases, the dirty stuff from that case, and then gets you prepared for the following case. While they're doing that, you can be running around looking for any special equipment that you may need for the next case, and that's what you want to do. At the end of the day, all cases, if it's the last case, turn off the machines appropriately, put the special equipment away back to the storage area, like the machines, microscope, cards, go back into appropriate storage areas to ensure only the OR equipment stays behind. In some rooms, the microscope may be in the room, and you may push it off to one side because that's where it lives. They say that's where it lives, meaning that's where it's stored. And some of the other equipment might be like the laser. That one goes back into this particular storage area, and so that's the kind of thing that you would want to do. Just make sure you put everything back where it's supposed to be, where you got it from. For your information, this information does not go into detail because it is understood that any nurse or surgical technologist must have an in-depth knowledge of all processes, policies, and procedures to function in the OR. This information is to give basic knowledge that will hit specific points that are to be used for ophthalmic surgery flow for surgical technologists looking to understand ophthalmics surgical processes unless otherwise specified.